All right, go ahead. Thanks.
Sure. So, like I said, I'm Brendan Striano. I'm one of the Robert Wood Johnson alumnus. I'm here to talk to you guys just a little bit of perspective on the residency experience and how to end up in orthopedics and how to decide if you want to end up in orthopedics. I'm a PGY4 at the Harvard Combined Program in Boston. Our program setup is a little bit different, and I'll talk about that a little bit as well. We don't have, most residency programs are associated with, one school and one hospital system. Ours is sort of split amongst 3 or 4 hospitals, which is why our program is so big. And so I can talk to that a little bit. And so I think probably what is most useful, since from what I understand, most of you guys are early in the medical school experience in the classroom years as opposed to the clinical years, is just sort of garnering or giving to you guys some of my perspective about how I decided orthopedics. And I think that the other thing I can give you is sort of my advice on how to do the first few years of residency or of medical school. And so I think that the first 2 years is probably best spent trying to decide whether or not you want to be someone who is in a procedurally based specialty or in a non-procedurally based specialty. And I think that sort of happens naturally. I think for me, it happened in the anatomy lab. I think for other people, it happened when they were shadowing and doing some of their clinical responsibilities in your first 2 years. But I think that probably is like the biggest breakdown. Some people refer to it as, medicine versus surgery. But I think probably more realistically, it's probably more something like procedurally based specialties versus not. Because there are some people who know they want to, do procedures but want to do ones that are through a medical training as opposed to a surgical training. And I think that figuring out if you want to do procedures or not is probably like the big landmark thing. And then the other part of it is the academic part. I think that I can't say enough about the importance of just doing all that you can to absorb the Robert Wood curriculum in the first 2 years. I think there's a lot of people who have the perspective of, if I want to go into something that I think is competitive, I want to get a great board score, and I want to start studying on my own early. And I would say that I followed the Robert Wood curriculum pretty much to a T and thought that it was like ideal for getting me prepared for both my, my standardized exams and just for being a resident in general. So I think that, you can't go wrong if you just sort of do exactly what they tell you to do. I thought that it was a very effective way to get through medical school but again, with sort of an eye towards whether or not, you think you want to be someone who does something procedural, if you want to be more medically based and not have procedures be a part of your day-to-day routine. For those of you who are a little bit more farther along in deciding that you want to do orthopedics and you're pretty interested in it, a lot of people in your shoes will start to wonder about how to get involved and how to see more of it. How do I declare myself as someone interested in orthopedics? And Robert Wood has a couple of good opportunities. Now, that being said, it's been a few years since I've actually lived through them, but there used to be fairly frequent, I think they were monthly research meetings that were a good opportunity to sort of not only get involved in research, but also get to meet residents and get to meet attendings at Robert Wood. I wouldn't be surprised if those meetings have gone virtual in the pandemic. And of course, there's Fracture Conference, which is a clinically based conference where they discuss all the fracture care that's happened in the last week or two. I forget exactly what the dynamic is. Jomar will know more than I will. There's another place just to get exposed because, for better or for worse, they know, and this is actually data driven, there is a shortage or a lack of musculoskeletal based education in all of United States medical education. And so there's a large part of being interested in orthopedics that just involves getting to know the lingo. How does an orthopedist think? How does an orthopedist talk about problems? Because there are things that come up exclusively in orthopedics. There's a lot of people that are going to talk about mean arterial pressure, whether you're a cardiologist or an intensivist or a pulmonologist or a internal medicine doctor. There's literally only one field where anyone ever uses the term valgus or the term varus. That's just only a thing that orthopedists talk about. So in your first 2 years, if you really think you're interested, it's great to see more and more orthopedics and just, hear the lingo, learn to appreciate how orthopedists think about problems and how they sort of assess problems, because it is fairly unique and something that is, not fully taught in undergraduate medical education. For better or for worse, probably practically speaking is a good idea because there's not that many people that need to know about it. But in reality, musculoskeletal care represents an enormous amount of the reasons why people present to a doctor, and it represents an enormous part of the financial burden of healthcare in the United States. So if you really think that you want to be involved in musculoskeletal healthcare throughout the rest of your career, it's good to just get involved and just sort of hear the words, so that when it comes time for your real clinical rotations, it's not the first time you've started to think like an orthopedist. And so they also are some resident clinics that, again, I'm not sure if, since the pandemic, if they're still running those resident clinics at Robert Wood, but that you can go to and just sort of see patients with residents and just hear how they talk about patients and hear how they think. I think that those are the real main ways to be successful and try to decide and differentiate yourself as you go through the beginning part of medical school. I think there's a lot of tropes about, orthopedists not knowing medicine. I think that in some ways those things are probably accurate, but I also remind you that competitive specialties are based off of, how well you know general medicine, not how well you know orthopedics. So at some point, whether or not orthopedists have forgotten a lot of medicine, at some point they were one of the, people in the class that knew the most about medicine. And my point of bringing that up is I can't say enough for just doing well in your classroom experience in the first 2 years, even if it's not orthopedics, even if it's not something that you find particularly, that you don't think you're going to need to know. You probably will need to know. And two, in order to sort of differentiate yourself into orthopedics, you're going to be tasked with knowing that stuff. So sort of stay committed to all that stuff, which I think Robert Wood does really well in the beginning few years. What, at risk of me just blabbering here at you guys for more time than anyone really needs to listen to me talk, what are there any questions about the process that you guys have? Or do you think it makes more sense to, I think I just saw Alex sign on. Maybe it makes sense to go through a couple of
sorry
people.
guys.
Oh, I see Joe Mar now. Okay, there we go. Maybe it makes sense to have, them say their part too, and then we can have questions afterwards, or, questions in the interim. Anything is fine with me.
Yeah, cool. That works. Jomar, Alex, welcome guys. Thanks for coming. If you just want to introduce yourselves, Brendan introduced himself. He talked about, going into orthopedics, why he thought it was important. If you guys want to do that, just tell everybody where you went to school, what you're doing now, why you chose ortho, and then we're going to open up to questions too. And then we'll go from there. I have questions written down too. So either feel free.
I'm Alex Decilveo. I'm PGY3 right now at St. Joe's in Paterson, New Jersey. I went to Robert Wood medical school. And why I went into orthopedics, out of all my rotations, I would say it was the one rotation that I actually enjoyed waking up for and that I could see myself doing every day. I had fun with it in both the clinical setting and in the operating room. And I think it's important to, although we've all been driven that this is educational and very educational mindset of a field, you still need to have fun doing what you do every day. And I think it really comes down to, it is a job and you need to love your job, but you also need to, you need to love doing it every day. And as you go through all of your rotations, you'll see what you really enjoy each day. And for me, that was orthopedics.
Nice. Thanks, Alex. Junior Aryee, PGY2 at Robert Wood right now. I went to med school at UVA, University of Virginia. Go Who's, undergrad in Virginia, grew up in Jamaica. Can talk about it forever if you want, but we'll leave it there. The reason I ended up choosing orthopedics was because I guess kind of the reason I wanted to be a doctor is because I wanted to make a huge impact in people's life. And I felt like, ortho is like a really high impact specialty. I mean, everyone always jokes you'll need an orthopedic surgeon at some point in your life, and sort of everyone, around you, you can't go 10 people without someone having said, they had some sort of interaction with an orthopedic or some sort of orthopedic injury or some sort of orthopedic musculoskeletal problem that really impacted their life. So I thought it'd be cool to be in that sphere. And then also being an orthopedic surgeon, you're sort of an expert. I tell people this all the time. You bring like a level of expertise that nobody else has to patient care. When all else fails, it seems the answer inevitably is call ortho, which you'd think isn't true, but I'm serious. Like, you can really bring some answers and help patients out in ways that, when medicine is stumped and these people are stumped and they're stumped, somehow it always ends up with us, and we kind of figure it out. So I think that part of it is awesome. And I felt like everyone I knew, or all the residents I saw and all the attendings I saw that, were in ortho, they kind of had this, like, kind of team vibe, and we were all, everyone liked the idea of like working together and being on a team. I did team sports growing up, so that sort of environment was very important to me as well. So all of those things came together, and ortho just seemed right.
Cool. Thanks, Jomar. So if anyone, I guess the best way to do it too is anyone has any direct questions, Brendan, Jomar, and Alex are here to answer any of that. They've been through the entire process. Brendan's almost done. So if you have any questions, feel free to ask. If not, I have a couple, but I'd like to open it up for now.
Yeah, Brendan, I have a question for you. You're PGY 4 now, right?
Yeah. Terrifyingly,
yes. What's the senior life like? Please let me in.
Our program is pretty front loaded in terms of like, clinical responsibilities, in terms of like, weekend call and all those things. So I am on the back end of that, which is nice. But I was, right before you got on, I was saying that the reality of having to be where the buck stops and you make the last decision creeps in more and more every day, which is surprisingly a little bit terrifying. Like, it's very easy, as I'm sure you've seen now, Jomar, you're a PGY too, so there's going to be interns who ask you questions, right? And they're like, oh, what should I do? And you look at them like, oh, this is easy. Like, you should do this. But you'll start to realize that when you are like the last person, that like even simple things like, oh, what should I do with this ankle fracture? And it's like, is this okay? Yeah, this should be fine. Yeah, that'll be fine. Like, this is okay. And you end up realizing that it's a little more nerve-wracking than you expected, just because that like I am the final say for some simple things. Obviously, still an attending involved in a lot of the real big decisions, but the reality of being the person that people are turning to is definitely a very true realization as you get further in residency.
Gotcha. With great power.
Brendan, what are you thinking about applying into? I'm sorry.
Oh, I'm gonna be applying into spine. So cool. I'll do a 1-year spine fellowship at the end of residency.
So we got some questions in the chat. I'll read them out. Feel free to, whoever wants to take it. So first one, I was wondering what made you pick orthopedic surgery over other surgical subspecialties?
I don't know, let me see if I might be muted. Oh, no, I'm not. I think the big distinction, if you're going to choose a surgical field, I think that you need to make the distinction between being a general surgeon and being a specialist, and appreciate that there is actually a really big difference there. General surgeons both not only have multiple pathways they can go down to become different types of surgeons, but you'll find that in clinical reality, they are often involved in more patient care decisions than specialists are. Right, so someone comes in and they're a traumatized patient, and they have a liver lac and an injured spine and a broken hand. They're admitted to a general surgeon who is involved in the minute-to-minute care making decisions. And depending on where you train and what the practice dynamics are like, for the most part, those people aren't admitted to a specialist. So they're not admitted to ENT, even if they have, horrible facial trauma. And they're not admitted to, plastics, even if they have a soft tissue defect that needs to be treated. They're admitted to a general surgeon. And so I think that distinction is important if you want to do a surgical field. And then I think that once you've decided, should I be a generalist or should I be a specialist right off the bat, you have to sort of have a good understanding of what each one of the individual specialties really deals with on a day-to-day basis, right? So like, the problems that I deal with as a orthopedic resident is very different from the problems that a urology resident deals with, right? Like, I'm not thinking about people's, kidney physiology ever, other than, as a comorbidity. Whereas if you're a urology resident, you're thinking about that all the time. And so sort of understanding the breadth of what these different surgical subspecialties do is going to be paramount in understanding which one you want to differentiate into. And I think the only way to do that is just exposure, which, you know, at Robert Wood can be a little bit difficult, but certainly not impossible, right? You just have to, you know, prove to yourself, you know what, I don't want to deal with ear, nose, and throat problems, because I think that saliva is the most horrifying bodily fluid that there is. And I mean that seriously. I truly think it's the worst one. So I would never be an ear, nose, and throat doctor. But like, there's nothing worse than someone being extubated and like some enormous spit loogie flying across the room. That's like truly my nightmare. So I could never be an ENT. And like, I think that eyeballs are gross. And so I don't want to be an ophthalmologist. And so the only way you can decide is to have a real understanding of what like the day-to-day is. And you really have to understand, like, what does an orthopedist do in society? Like, they are the person tasked with getting people back to the physical function that they want, whether it be nerve decompression or fracture fixation or arthritis care. And that is unique to orthopedics, that you know, other people are doing that to some degree, but it is not their day in, day out bread and butter. And so if you want to be an orthopedist, I think you have to want to deal with that patient problem.
Yeah, I agree. When you are figuring out what subspecialty you want to go into, I think getting the exposure in med school can help a lot. Obviously, it's just a little taste of it, but when you have that elective time that you're not going to be doing orthopedic away rotations, it's really good, like on your surgical rotation, to maybe do an orthopedic elective. But then I did like ENT, and I realized on my ENT rotation, I was in the office so much and not operating nearly enough. And I wanted more of that operative exposure. And then contrasting it with my general surgery rotation, which I really did enjoy. I enjoy elective procedures, and, you know, each person is different. Some people like more pressure with an emergent procedure. I like the relaxed nature of elective procedures, and there you can find that in many surgical subspecialties, but what aligned with me most and my interest in terms of musculoskeletal system and elective procedures aligned the most with orthopedics.
Yeah, just has to be you. You know, I think that probably my one of my advice points would be not to be lulled by the people who you're working with. I guess you know, in some sense that's one thing to look at, because those, you know, that specialty probably tends to draw those kind of people. But there are just like awesome people who are doing things that you like otherwise may not like. So I think probably really looking into, again, the day-to-day issues that, you know, probably for me, I think the way that I'm ultimately going to choose, like, you know, what I want to do in ortho is like, what like complications, what like problems am I just like, I can't. And that's probably a good way to think about it. You know, what do ENT people deal with, like saliva balls that you just can't? What do general surgeons deal with, like those drains? I just can't do it. They just keep coming, and there are just so many of them out of the abdomen, so I just can't. So, like, you know, like that's like, if you just aren't able to tolerate some complication or some problem that is like a regular part of what that subspecialist does, I probably should be rethinking it. So definitely look at what you're unable to do. I think that you'll find that, you know, a lot of the things that are, it's hard to tell exactly what you'll love and until you kind of do it, but pretty early on and pretty easily you can tell, like, this is just not for me. And so I'd probably cross things off sooner than just kind of and kind of have a wide net, cast a wide net, and just see what falls off. So definitely that exposure, being there, being as present as you can, you know, taking that, you know, one of those 2 days off to shadow something and make sure it's, you know, it's really what you want, because once you're locked in, you're kind of locked in. So.
Cool. All right, next one. How's work-life balance in residency? Do you think it's different than the work-life balance as an attending, or similar?
God, it better be different. Please. it's I think probably the thing that you start to get more and more is you see more and more is that like you not only have less time, it's that less of the time is yours. So there are just less minutes that I can guarantee belong to me, and I can guarantee like I can do X or Y or Z with. That's probably the hardest part. So it's like, even like scheduling this meeting, like coming today was like, is it going to happen? Is the pager going to go off at X minute of the, that's probably the hardest part, which is also factoring into what I'm going to ultimately do. I need schedules. That works much better for me. And so there's not a lot of that very early on in your career in ortho. Most of programs are front loaded. Most of interns like hate themselves. And like you tend to start liking yourself a little bit more and more as you go along. So that's like, it's tough, but if you have people around who can kind of take care of you, that's been like, my like anchor. My wife has been like, there for me, which has been awesome. So that helps out a ton.
Yeah, the work-life balance is hard for any surgical residency. I think the distinction is going to be between a surgical and non-surgical residency in terms of the amount of time you get to yourself and the amount of time that is yours. General surgery, they're working just as hard as orthopedic residents are. Unfortunately, a lot of the spontaneity in your life, especially that you have in fourth year, kind of disappears when you become a resident, and a lot of things have to be planned. And a lot of the times you don't have control over your schedule. Usually you're working at least, in my program, we work at least 2 out of 4 of the weekends when you're on a 24-hour call your first 2 years. So you got to come into it knowing that you're only getting 50% of your weekends out of the year. And, you still got to factor in, things to maintain your life, whether, that's cooking or seeing family or friends. And so that's cutting time to yourself down even more. So it's definitely hard. But, I think after your second year, you start to get a little bit more time to yourself, a little bit more time to study, to become a better resident. And, each year that gets better. And I think, as an attending, just from what I've seen when you're starting out, it's a little rough, just getting your feet under yourself, establishing your practice. But, as time goes on in the first 5 years, it seems to open up a lot more, and, you're building your family or whatever the things that you like to do.
I think that the work-life balance question, it comes up a lot in a lot of different formats.
Federal and local regulations require that all persons, including those vaccinated against COVID-19, properly wear a facial covering over your nose and mouth in all areas at SFO. Failure to comply may result in a fine and removal. Thank you for supporting safe travel.
So I think that, like I said, it comes up in a lot of different questions. And I think that the people who tolerate residency the best in terms of, the frustration of like the change in your work-life balance are the people who don't come into it like sort of expecting to have the same life they had pre-residency and then also do residency at the same time. Because I think that the reality is that like your life is just vastly different. Like if I look at what my day-to-day life was like as a MS4, it's just so vastly different that when I look at it that way, it's like, wow, I've had to give up my entire, social life as I knew it 5 years ago. But if I look at it from a different perspective and you focus on making what time that you have off into things that you like doing, it really isn't so bad. And so I think a lot of it, maybe the simplest way to put it is a lot of it has to do with perspective. Like if you are just very appreciative for the time that you do get off and you do the things that you like doing, even if you're tired and you don't want to spend 4 hours of your, one weekend off driving somewhere. If you just do it, you end up having, plenty of your personal life still around. even during residency. And so I think simply put, it's a lot about perspective on what you're expecting to residency life to be like.
Yeah, and you can see how, like, just in the scale of things, how things get better. Like Brendan, are you at an airport right now?
I am currently sitting in an airport, correct.
So the PGY2 is like late. He can barely make it in. He's dying on consoles. PGY3 is here on time. The PGY4 is like just chatting to you on his way to take a flight out. So that's how the life sort of like progresses as your time goes. So, again, less time for you, but it does get better. Maybe, I hope.
It definitely does get better.
Oh, thank God.
It gets at a very minimum, it gets different. It certainly gets different. Like, do I spend as many days in the hospital dealing like rubber meets the road with consults? No. Do I get more phone calls in the middle of the night from junior residents asking what to do with consults? I get more of them, mostly because I used to get zero. But yeah, it changes. It changes a lot. And someone else had asked a question about, in terms of work-life balance questions, like what time are you getting in and out? I think that for my residency, super varied, depend on what rotation you're on. If I was on a trauma rotation, I'd be getting in at 5 and going home at 8, even as a senior. Doing foot and ankle surgery, I was getting in at 6:15 and going home at 4 or 5 p.m. a couple times a week. So it varies a lot. It varies a lot within your hospital structure, within your residency structure, in terms of what your rotations are like. You want an elective rotation or you want a trauma rotation. The hour to hour is highly unpredictable. And I think that probably goes pretty much for all residency programs across the board.
Yeah, I was going to bring that question up. Thanks for answering it. All right. So here there's one about how common is it taking a research year during med school to be competitive for the match? And just, I'm sure you're all aware, but STEP is now pass fail for all of us probably on this call if you're younger than an M2. So how that could factor in as well.
Can you guys hear me? I got like shoddy reception right now.
Yeah, you're good.
I didn't take a research year, but I did use my first year summer to get research done. So I've had multiple people say research matters, research doesn't matter. I think they came out with a study where like they polled all the program directors in the country. And I can't remember the number or like where research falls on importance of applications. I would say it's safe to at least get one publication or have worked on a couple projects just to be safe. But I don't know if a dedicated research year is necessary. I think if you use your time well and can manage to get a project out while in medical school, then that would be great. Some people like the research year to, explore, take some time off for themselves and also do research to make themselves more competitive. And I think that it has value in that sense. And then in terms of, I truly have no idea how it's going to be taken.
Yeah, I think that the STEP question is completely unanswered for everyone, including program directors and chairmen. I don't know if you guys have started having meetings or talks yet with like your executive committees for your residency, but I don't know that people have any idea of what to do with that information now. In terms of the other question, I think that a research year, people can use it for very different things. If you want to have a career in research and you want to get better at doing research, I think doing a research year to hone your skills makes a lot of sense. I think that if you're a competitive applicant and you want to make yourself a super competitive applicant and research is the one thing you're missing, then sure, I think research year makes sense. I think the only time that you have to be careful about a research year is if you see yourself as a on the border applicant, you're like, maybe I'll match, maybe I won't, if you're honest with yourself. I'm thinking that taking a research year is going to use that to sort of put you over the edge and be someone who's definitely going to match. I think that is a risky move to make, because I don't know that always is such a slam dunk idea. And so I think that the value of research here has a lot to do with what you expect to get out of it. If you want to get better at doing statistics and familiarize yourself with clinical research, I think it's a great idea. If you are seeing it as a way to, like, just get over the hump of being a competitive enough applicant to match, I think you have to be careful about doing a research year for only that reason.
Yeah, I think that at this point, like, some sort of research, whatever it is probably like a required, like just anything that shows is kind of almost required, especially without like the step one. I think that most of the program directors I've spoken to have said that now that step one isn't there, like step two sort of becomes the next thing that they're going to be looking at, the next proxy. So it just shifts the burden, I guess. But I don't know, everyone's coming up with their own metric. A lot of the fourth years I talked to this year said there are like a ton of secondaries now, and there's like, some places asking for like a little video, like 5-minute videos of who you are and stuff like that. So people will get creative on how to whittle down their apps and how to see who's really interested and so forth. So I'm not sure exactly what they'll do regarding that, but I think that a research year is only like useful if you like, you absolutely have no research, or you just really didn't know that you were going to go into ortho, and you think that you need to have something on your tail end, or not that it's only useful, but it's particularly useful in that scenario. I think that if you do a research year and you get a ton of research and you get a lot of experience, it can be really helpful for you, because you get to see those things that we spoke about before. Like, you can shadow and you can follow people around, you can see the day-to-day and see what you like and dislike about ortho. So it can be more than just doing research. You can kind of show people that you've invested time in this, and people like that. People like people who will kind of invest in things. So.
Thanks for answering that. Oh yeah, do you see anything else, Jomar? Anything else?
I'm looking at if there were other questions.
There's one about so I guess this is more for like M3 and M4s. I mean, I guess us too as M2s. Are there specific resources you recommend for building a strong foundation in orthopedics, since so much of it is unique from the curriculum? Thank you for taking the time.
Yeah, I think that for me coming in, probably the thing that like you just couldn't beat me on was anatomy. Like like it's probably the most important thing. Like, every so often I'll like zone out and I'll miss something, or if I'm just not there, I'll like completely like blow something. But like, if we're like if someone is talking to you and you're paying attention, which you should always be as a student, like, you should know like any an anatomical question that someone asks, just because it's the foundation of what we do, right? Like I like loved anatomy, I taught it, I did all this stuff. So, it should be like second nature to you. And once you have all that down pat, like a lot of the physiological processes, like, even in trauma, like talking about like, when people start talking to you about things like deforming forces, you can sort of and what muscles are pulling bones in what directions, and understanding why things break the way they do, and understanding, why ligaments are kind of break in the or get disrupted in the order that they do. Understanding all those things, you can't unless you know just where everything is. So I think that, and what controls what, and it makes things, I think, a lot simpler for you, because you have to memorize some things, so memorize anatomy and then kind of fill all the physiology in behind that. So that would, netters is going to be like, the key. Like, read that like every day. It's your gospel. And beyond that, I think that, at Virginia, they had like a really good like 4th year ortho curriculum, which is something I hope to like bring to Robert Wood. So hopefully many of you on this call will kind of be recipients of that. So that I think was also really, really useful for me.
Yeah, I think hands down, I think anatomy is the answer. There's no orthopedics. There are too many rabbit holes within orthopedics as a student to try to figure out which rabbit holes you should dive down. And so trying to understand the kinematics of knee flexion or pronosupination, you would get lost doing any of those. As a resident, I still get lost down those rabbit holes all the time, but you can never go wrong knowing your anatomic relationships. It is truly, like Jomar said, it's the foundation for everything that we do. And so if you were going to just absolutely nail something as a medical student, it would without a doubt be anatomic relationships.
Cool. I got another question about research, but during your time as a resident, so how much of your time is still dedicated towards research?
I don't know about you guys. I don't have any dedicated research time. Research is a thing that you make happen because you want to do it in between all the other clinical responsibilities you have, in my experience. So there are lots of people in my program who don't do really any research, do one project in their 5 years. And there are people who publish 6 and 7 times a year, but I don't have any dedicated research time.
Yeah, and so I'll second that. Actually, it's not true. There's like a 2-week block as a 4th year. I think that they say you can do research. So anyone who's done research knows that that's kind of like
that's a vacation.
That's a joke.
that is a vacation.
Yeah, you can't do research in 2 weeks. That'd be silly. But yeah, so there's no time. I think as you get some more ownership of your time as you progress through residency, you can probably dedicate that more or less. And I think the environment of your program also helps. I think at Robert Wood, there are a couple of attendings who are really excited about doing research and will take you on under their wing if you have an idea, or if they have an idea and they're happy to have you work on their stuff. I'm trying to juggle up 2 projects at once, and it's deathly stressful because it ends up being the one thing that kind of just gets kicked down the road because consults needs to be seen now, or you need to be ready for the OR tomorrow. So it can be a little tough, but I try to. I'm trying to work on a couple of things. But that's that's because I want to. No one is making me, and if I just told everyone I'm out, that would look terrible. So I'd never do that. But I could just stop after this and no one would even bat an eye at all. It wouldn't even matter.
Yeah, we don't, I know there are a few programs that have a research year that some people choose to do that research year, and then some people are actually forced. It's kind of like a flip of a coin. But at my program, we don't get any dedicated research time. You kind of just juggle it, as Jomar was saying, and then as you get farther into your residency, you get a little more time to dedicate to those things if you'd like. But there is a research requirement, and our research requirement, kind of like what Brendan was saying, is we only have to do 1 project in 5 years. So.
Yeah, and that is actually like Alex was saying, you have to do a project. It's a pretty liberal interpretation of the word research project, because that's a requirement of the ACGME for any orthopedic residency. You have to have done 1 project, but it does not have to actually be published. It can be an internal stuff. It's a pretty wishy-washy requirement. You have to do something, but it's not something particularly stringent by any means.
Yeah, I think the verbiage is it must be in a publishable form. So if you have an abstract that possibly could go out that can count. So it's like the bar is really low for what you have to do. So anything you do above that, it's up to you, like you want to do that. So, and you can find time, you can find people who are willing to, but it's tough.
Yeah. And there's also, when you guys, if you decide to apply to orthopedics and you're interviewing, there are programs and you'll get the feel of it, to which ones strongly encourage research and those that are more lax about it. And, depending on what you want to do, those are things to consider when choosing a residency and, what fits best with who you are, because when it comes down to it, in terms of like choosing a residency, what I believe is to choose the place that best matches you and what you want. So
I couldn't agree more. I think that people set up this false paradigm when applying to residency where there is a hierarchy. And people think it's a hierarchical, like, oh, this place is better than this, is better than this, is better than this. And I think that in actuality, there are different training programs that prepare you differently for different things. And I think that people are the happiest when they are able to understand that it's not a hierarchy and that you have to just pick a place that geographically or in terms of, style of people, size of program, whatever have you, matches what they want. And that it is not I need to be at the place that is quote unquote the best. And if I go anywhere else, it's a failure. It's like acknowledging that. In fact, there actually has been a research study looking at what is the most important factor in someone deciding where they do residency. And actually geography is consistently the most important. Because if you put someone in a geographic location where they don't want to be, whether they're in a rural place where they want to be in an urban environment, or they're in a great program, but they're 2,000 miles away from their significant other who can't move with them, they are unhappy. So geography is the most important thing, not how many hours you operate, how many tibial nails you do as an intern, not, how many hemipelvectomies you do, and anything like typically goes along with, what is a better residency program. It is geography. And so simply put, orthopedic residency is not a hierarchy. There are different programs that provide different things, and you have to just figure out which one meshes with what you want.
Nice. I actually had a question, just for like me personally, and for I guess the M2s that are going to be M3s next year. So when you were going into your third and fourth year rotations, I guess specifically in like a rotation that you wanted to match into, like orthopedics, what did you do on that rotation to stand out and prepare to feel like you were making a difference, to feel like that people actually noticed you without being annoying?
You're saying as an M3?
Yeah, as an M3, and then I guess on your M4 elective, but I guess more so as an M3 because I'm sure there's a lot of M2s on the call.
Yeah, I wouldn't try to stand out too much as an M3. You just can't do it right. It's like, or at least it's very tough too. I think being an M3 when the expectations of you are like really low is a good time to like keep your eyes like wide open and keep your ears wide open and really like pay attention to what people are doing in the program, because some people kind of remember you when you're a 4, and then the expectation as a 4 is just like you know how to do stuff somehow, so I think that probably the best advice would be like really follow, like look at what the M4s are doing, like look at it. Yeah, if you want like to do well, like see what they're doing, and like you'll see what the residents like and dislike, and like don't make the mistakes and make the good choices. Like people will talk and they'll say, oh, wow, this student does X, Y, and Z, like jump on that, like if student A is killing it, like follow them, figure out what they're doing, how they do it, what resources they're using, etc., and like nail that for when you're a 4, so you can be student A as well.
I think the med students that I remember the best and who I have the fondest memories of are people who are the 3 A's, right? Available, so there, just have to be present. You have to be affable, so just get along with people, and you have to be able, as in good at doing things. But I think that the one thing in addition to that, like common cliche that you hear about the 3 A's, is people who are intuitive. who, don't have to ask me what they should be doing, because a lot of times as a resident, there's like 4,000 things going on in your head, and you're not just worried about the task at hand, you're thinking about the 10 other things that are going on in the background that you're trying to keep track of. And so having someone ask you what you want, what they can do to help, is often like, it takes more time for me to explain it to you. So I think the people that are best are the people who are intuitive, and it's not like major things, right? It's like, oh, okay, we're going to go see an ankle fracture in the ED. Why don't I go and get the history from the patient, and I'll grab, 3 rolls of plaster and some web roll and some ACE wraps, right? And then by the time I finish what task I was doing and I go to see the consult, the med student has like, oh, he's a 24-year-old healthy guy. He was playing soccer and I had slept for a splint. It's like, wow, that's amazing. This is like, you know what's important and you know how you can be helpful. But like, you can't reduce the ankle yourself. You're a med student. But if you are able to think ahead and say, oh, we're going to need splinting material, that's great. Like, you want to roll out splinting material, even better. So just sort of be intuitive and be present enough cognitively to be thinking ahead one step, so that you can, stay ahead of what the person you're working with. I think is like, not only what, like, sure, it's good to be a good student, that's important, but it also is what sort of sets you up for being good as a future orthopedist. Because I'm sure Jomar and Alex will tell you, like, a lot of times the most important thing that an attending is thinking about is what's the next thing, right? Like, do whatever is at hand is one thing, but like, what's the next step is like what the attending is doing. So as you get further along, you start to appreciate that more. So if you can model that now early on, I think that just makes you like far and above, the type of person that's the best student.
Yeah, I would, what Jomar said about not trying to stand out as a third year, the expectation is when you're a third year is that you are just kind of like a sponge. You're just absorbing everything. And your job there is to observe and, lend a helping hand as needed, but really is just to see if orthopedics is something you're interested in. And then, so it's a good time to really see what the fourth years are doing, and, what the interns are doing and how they're helping each other, and kind of model that. And then, kind of like what Brendan was saying, I remember on my aways grabbing, doing that exactly, going and grabbing web roll and ACE wrap and plaster, and sometimes grabbing the wrong sized plaster. And even though it was the wrong thing, it was initiative. It showed that you wanted to help. And unless that resident was a horrible person and they would get angry about that, they would teach you so that you wouldn't get it wrong the next time, and then so that you could help out properly. And I think that in your fourth year, really just being prepared for your cases in terms of anatomy is what's going to help you stand out. And definitely third year, kind of just learn, be nice to everybody, be normal. Don't be too talkative, but just be yourself. And people will appreciate you just being interested in orthopedics.
Being normal goes a long way. Couldn't echo that more. Like, no one is expecting you to be like God's gift to sewing as an MS3 or MS4, but some of the people that stand out the most are people who are not normal. So just being normal is a huge step in the right direction. I think that's like, I give that advice to people rotating with us all the time. What can I do to stand out? Don't do anything bad. Stand out for being normal.
Also, we had a few med students that sat down in the OR on like standing cases. Don't ever sit down unless you have like a back problem or some sort of medical condition that requires you to sit down.
Yeah, if you're drawing attention to yourself for doing something that's different from what everyone else is doing, you're probably making a mistake. And there was another question in the chat I saw. Let me just quickly review what it is. Why did we choose our respective programs? Unsurprisingly, geography was a huge part of why I wanted to be in a big city. My now wife was following me a year after, so we did a non-true couples match, but she had to be able to match in a city that I was in. So, being in a rural area where there's one program for a big radius was not going to work for me. The thing I liked the most about the Harvard Combined program was we do actually do more of the medical management of our patients, which I've gone back and forth about being glad that I do that and not being glad that I do that. But those were like the two things that stuck out the most to me was, how much medical management we do of our patients, and just being in a city where, my significant other could follow me and have a place to do her residency too, and not end up, 1,000 miles apart.
Yeah, and so for me, as I looked at different places, I think that probably the most important thing for me was like somewhere where I got the sense, at least, that it's going to be a team. It's like, it wasn't going to be like, even if there are a lot of people, like it can still be like a team. I just wanted like to do ortho with my squad, I guess. So I felt like that's something that when I interviewed here, I got that sense from the people who were here. So that was probably outside of like, so my when I moved from Jamaica, I moved to Jersey. My dad's like side of the family lives kind of an hour-ish away. So that's helpful. I never get to see him, but but it's the thought that counts. And so like that was something that definitely, again, geography is like, I just didn't apply anywhere that I absolutely couldn't live. So geography is super important. But again, like also the next important thing was just like, people just didn't seem divisive. People didn't seem like they were going to like cut your throat for no reason. People seemed like they were friends. So that was important for me. Of course, COVID ruined it my first year here. Like I'm not allowed to like talk to anybody. So there's that, but yeah.
I think we probably have time for one more question. If anyone's got anything else.
Just to finish up that, I would say geography was most important for me, being near family and friends. I grew up in New Jersey, probably about 30 minutes from the residency program that I matched at. So that was really important to me. And then as well, just like group dynamics. I did an away rotation here, so I got a good sense of how the residents interacted and how the attendings were. A lot of the attendings were alumni of the residency, as well as like local people from New Jersey. And that was just really comforting to me. And also, I wanted a smaller program, not as like a large program. So that was one of the factors that went into deciding.
Well, even if you guys don't have any more questions now, I'm sure that you will come up with questions as time goes on, whether they be, specific to your, application or your, specific scenario, or just general questions about orthopedic or life or whatever have you. So I put my email address and phone number in there in case anyone wants to reach out. If anyone, some of you, I think I recognize some names on here of people that have reached out in the past. And if you do, you'll know that I keep things pretty casual. And if I don't respond to you, it's mostly just because I'm not paying attention. So feel free to email me twice or text me twice. I know I had a lot of hesitation about doing that as a med student, but do not hesitate when it comes to reaching out. It's most likely because the person, especially for me, has just lost track of their text messages or emails for the 1,000th time. So feel free to reach out with other questions and things. We're happy to keep this line of communication open. This does not have to be a one-time thing. This can be an evolving conversation.
Yeah, definitely second that. Pascal, PJ will tell you, I have like 2 phones. So like, it's I don't know, my life just kind of exploded a little like intern year. So I'm still picking up the pieces. So if I don't get back to you, it's not because I don't like you or don't want to. I'll always, if just see me or like say, hey, did you see my email or something, like, and I missed it, I'll get to it, I promise. But sometimes it's, just busy.
When your life explodes into a year, it doesn't ever get put back together, at least not by PGY4.
Oh,
I still find pieces of my life just scattered around Boston regularly.
Terrible.
And if any of you have trouble getting away rotations at St. Joe's, just reach out to me, because sometimes the program director or the secretary has trouble sorting through applications. And every time she mentioned someone from Robert Wood, we always try to get you guys in. So I left my contact information there as well.
That's great, man. That's our away rotation program is so horrifying. I like to caution people about even doing it. It's decided entirely by the registrar of Harvard Medical School and has nothing to do with any orthopedist. It's truly an absolute shambles. Painful reality. Well, I'm sure, like I said, you guys will have questions as you keep marching along this program here. So feel free to reach out at any time. Anything else we can help with, PJ?
I think that was it. Thanks, guys. We really appreciate your time, just being so open and just honest.
This is a security advisory. Please maintain possession of
yeah.
bags at all times.
Again, if anyone has any more questions, feel free to reach out to Brendan or Alex.
911 remaining phone.
But yeah, I think that's really it. Everyone that came, please sign the attendance form. Peter put it in the chat. I won't end the meeting just yet. You guys can take the numbers down. I want to close it out, because then the chat will be gone. But other than that, there's no more questions. Thanks for coming, everybody.
If they ever have like an alumni vote for best alumni, don't hesitate to put my name down.
What the hell? I would put him down. Throw my hat in the ring too. Yeah. What does that take to be best? What do you think we should get? What should we ask Dean T for being the best alumnus? Like a plaque or something? Well, that would be good. A plaque on the wall.
That's just funny. Kidding. Thanks, guys.
Okay, don't be strangers. Thanks a lot.
Thanks, guys.
Bye.
Take care.